We're going to invite Aaron and
Grant.
Thank you, to have an open discussion now. So any questions from the audience? Carol?
Specifically detox. I would love to hear about access to care, specifically detoxification.
Grant would love to tell you about that.
Yeah, unfortunately, I don't have any work that CDC has done in the area. It's really been focused on addressing the issue of MAT capacity. I worked on a paper with Chris Jones earlier this year showing that there's a gap of a million. Sorry, there's a gap of 1 million between folks who need opioid MAT services and those who are actually receiving it. But I don't have broader information on detox. I would defer to my colleagues at SAMHSA. If you want to send me an email afterwards, I'll try to make a connection to SAMHSA in that front.
If I can ask you specifically, what do you mean by access? Do you mean how available is it, or how often is it used? Or, I ask only because we just went through this exercise at NIAAA the other day, and somebody raised the question of, is there a shortage of treatment availability? Is that why people don't get treatment for alcoholism? And the answer is no. They don't get treatment because most people don't recognize they have a problem, and even those who do choose not to pursue it. So I just wondered if you meant if there's care available, or if people don't use it, or if people want it but it's not there. And I can't answer either of those questions, so it doesn't really matter.
Other questions for the panel? Yeah, Marcy.
Earlier, somebody mentioned the maximizing the use of the prescription drug monitoring programs, and I'm wondering if there's any evidence of expanding access to the information, whether there's any impact on utilization or access to services, or identifying the population better. And the reason I question that is we've had this discussion here in Michigan that the only folks that are able to really access that are physicians, yet, it may be helpful for law enforcement, it may be helpful if social workers, therapists had access to it, if that's happening anywhere else in the country.
Sure, that's a great question. I was the one who mentioned that. Unfortunately, we didn't talk a ton about prescription drug monitoring programs today, but it's one of those things like if you've seen one PDMP, you've seen one PDMP. There are 49 states that have an operational prescription drug monitoring program. Missouri is the only one that's an outlier that still doesn't have one, although we're holding them accountable. We have heavy expectations they're going to pass one. We were expecting them to pass a PDMP law last year. We're hoping they'll pass one this year. Part of the reality for PDMPs, as you were hinting at, is that there's really broad variation in sort of how they're stood up. So they're funded from the several $100,000 range to the several $1 million range. And there's good evidence, actually. Christine sort of highlighted it a little bit in her presentation, but the Kentucky with their House Bill 1, New York with their iStop legislation that mandated use of prescription drug monitoring programs, they have been shown to reduce prescribing and ultimately to reduce overdose-related negative outcomes. So, but as I mentioned in this most recent presentation, we don't really know enough about what truly is enhancing and maximizing prescription drug monitoring programs. We do have the 35 or 36 best practices that the Brandeis Center of Excellence has outlined for PDMPs. We think, and I've mentioned what we think they're sort of the 5 or 6 critical of those 35 best practices are. And we're hoping I think all of the, don't hold me to this, but all or nearly all of the prevention for states that are funded are one key component of their application is better linking PDMP to health outcome data in states to sort of triangulate data, answer some of the questions that Dr. Prusnik highlighted, answered some of the issues that you've raised as well. So we think there are real opportunities. In my home state of Georgia, we have similar problems where a pharmacist can actually contact a doctor if they identify somebody who presents to them, and the doctor who wrote the script to check in with them. So there are real barriers to that Other issues within PDMPs, and I'll stop talking in a second, but it's a passion issue of mine, are issues around interoperability. So folks who live in border areas, like here in the south of Michigan, a lot of PDMPs, we need to make sure that they can talk to one another. So people who are going across the border to Toledo, for example, those PDMPs are checked. The issue of integration to electronic health records is critically important. Single sign-on is another issue, so that part of the issue is in some health systems you're having to go to a separate computer to sign on. So in that very brief clinical encounter, you really have to be a judicious clinician to want to go do that. So making it easier for a physician, then they want to, the lion's share of them want to do the right thing, making them have that information at the point of care in a readiness way is exactly what we're aiming to accomplish. So.
Right, thank you. So let's go this side of the room and then we'll go back to that side.
So going back to insurance and those types of things, has there been any research done or any talks of getting with insurance companies? Because oftentimes providers try to get the right treatments for their clients that are needed, but they can't because they're blocked by what insurance will pay for, the length of stays and programs, those kinds of things. Has there been any thought or discussion around that?
Sure. We've had good, and I think Michael can answer some of what Group Health has done. They've done some very impressive work. We've been working with Kaiser Permanente as well around how they've implemented things like coordinated care plans. So for the select number of patients who do have a legitimate medical need to be on long-term opioid therapy, they have put a standard of practice and care within the Kaiser network, and they've seen dramatic improvements or dramatic reductions in negative outcomes associated with that. I'm trying to think what else I wanted to say. So it'll come back to me. If you want to restate your question, I apologize. It's late in the day.
If patients are trying to reduce their opioid use, or
if they're trying to reduce or come off of their opioid use and the services or resources aren't available to necessarily allow them to do that.
Sure. Michael, maybe you can answer with some of the coordinated care work. You guys are doing some of that, are you not? Okay.
Addiction medicine specialists in our integrated group practice, but you get out in rural areas or most places, and it's a big gap. And I don't think the coordinated care plan is not the solution to this mess.
Okay. Over here.
Is there any consideration to limiting direct to customer advertising? Are there experiments like that going on? Any comments on that?
I don't really have, that's really an FDA issue. So I will say that CDC, in partnership with SAMHSA and others within the administration, are working on both physician and consumer-facing communication campaigns. You've heard a few communication campaigns really highlighting the serious, sort of giving a perspective on what the realities of opioid use are. So we've seen a number of state-based examples today, and we're looking to sort of grow that. But we don't really, CDC doesn't deal with sort of regulating marketing of drugs. So, but it's an important question.
Allison, did you have a question?
So a number of the speakers today have talked about the unique iatrogenic component of the opioid issue and potentially the importance of helping providers more safely prescribe these medications and some of the chronic opioid guidelines that you talked about as well. I was curious from a national perspective, what are thoughts and also specific concerns about interventions that might be targeted at providers?
I'm not sure I'm understanding your question. I mean, given the fact that I think we all agree it's an iatrogenic problem, I mean, I think it's important that, we believe that prescribing got us into the predicament that we're in right now, and that ultimately, we can do a ton of important downstream interventions, some of the harm reduction work with naloxone, some of the medication-assisted treatment, all the evidence-based practices. but ultimately we have to change prescribing practices in this country. And I think, as has been mentioned a couple of times, I think individual doctors, health systems, and the federal government all have a role. State, obviously the practice of medicine is regulated at the state level, so states, it's part of why we have so much energy at CDC in supporting the Prevention for States program. That's really where the rubber meets the road with the practice of medicine, where physicians are licensed and whatnot. So I do believe that there's enough blame to go around for this iatrogenic problem, and we all need to collectively come together to solve it. And I think the data are what the data are. It's very clear. It's incontrovertible at some level at this point. So we now, I think, need to shift into, so what are we going to do about it? How can we make a difference? And I think we're beginning to know what those things are. We've seen some states have some success, and part of what we're interested in doing at CDC is showcasing those successes. So taking those case examples and telling those stories so that other states can adopt those same strategies or tailor them to their state-specific needs to turn the tide, and both on the prescription side and on the heroin side. And Dr. Frieden regularly remarks that it's not just a public health problem. It's a law enforcement problem. It's a community problem. Everybody, it really is. I think sometimes multifaceted and multi-stakeholder is a sort of is an overused expression, but in this case, it is exactly that. Everybody has a role to play. But ultimately, in my view, and I think broadly in the CDC agenda, it's really around making sure that we rein in inappropriate prescribing. Again, opioids do have a legitimate role in the practice of medicine. We just need to curb inappropriate prescribing.
Piggybacking on the last question, the publication that you talked about today with the that's coming out in January, the recommendations on prescribing opioids for chronic pain management, is there a plan to address acute pain management? Can we talk about unused meds being left in the home and the extent to which clinicians who have outpatient practices, dentists who say, here, I'm going to write you a script, just go ahead and fill it, use it if you need it, and the meds get unused and left on the shelf, and the extent to which possibly clinicians may not self-identify with a recommendation publication like that because they're not managing chronic pain in as much as they are acute pain.
Sure.
Are there plans to address that?
At present, CDC does not have plans to develop acute care guidelines, although we're well aware that other professional societies are actively involved in doing just exactly that. We've had good recent conversations a few years ago. The American College of Emergency Physicians came out with ED guidelines. I've had conversations recently. I think they maybe wanted to update those. The reality for us is that, we think there are some, again, in the health system arena, we think there are some easy low-hanging fruit. So changing some of the system defaults. So, if you have a wisdom tooth pulled, you don't get a 30-day script. You get a 3 or 4 day supply. So some of it is about sort of building into practice, making the default healthy and safe. But at present, we don't have plans on developing acute care guidelines. But it's an important question. It's an important issue. We have a lot of energy. Given the burden that I tried to outline, we think that that these guidelines, if disseminated and picked up in the way that we think they should be, that they're sort of adapted and tailored in the ways that make sense, and physicians can still have the broad opportunity to handle each patient on an individual by individual basis, we think they can make a big difference.
We have time for a couple more questions.
I just wanted to piggyback a little bit more on the insurance piece, because I don't know if didn't hear the answer kind of quite clearly. But
Sure.
Is anybody working on parity around treatment for people who have substance abuse issues, as well as I work in the adolescents? We have a huge difficulty getting insurance to pay for long-term treatment for these children who, in their adolescence, are developing substance use issues. I didn't hear the kind of if there's any sorted effort for parity around that population.
Yeah, I think it's a really critical issue. I do think I'm not as familiar with that line of research, but I will say that we need to be, we have a moral responsibility, we have an ethical responsibility to make sure that folks that their pain is properly treated, and so working with insurers and others to make sure that other modalities are available that have been proven to be efficacious, that they're available and covered, makes a lot of sense. I think it's an important. It needs to happen. So I'm sorry I can't give you a more detailed answer. I apologize.
Yeah, this is Jack. If you guys can hear me,
Yes.
I could just chime in a little on that. Some of our health services research is looking at some of those issues, so I'm happy. You should have my email. Happy to respond to direct inquiries around that from the NIDA portfolio. Also, the Agency for Healthcare Resources and Quality (ARC) has been doing some much more work and will plan to do a lot more work because they've gotten some congressional mandate to do so on MAT implementation, which would probably include some of the issues you're talking about. And then, of course, CMS, Medicaid and Medicare Services, is looking at a lot of these issues. But it clearly is at the root of so much of these challenges on the implementation piece. So I'm hearing that loud and clear on a lot of the questions that have come up today, and I'm happy to filter through any of the NIDA research in that area and make sure I share it with the conference organizers.
Right. Thanks, Jack. We have time for one last question.
Hi. Hello. Hi, I'm curious to hear from the panelists your thoughts on community-based pharmaceutical disposal options, where we've talked a lot about prescribing patterns, but once medications are already out in the community, how do we prioritize resources to help people get rid of unwanted medications?
Yeah. We think take-back programs are one piece of the implementation strategy to turn the tide, but we don't think it's, if I was to sort of stack rank interventions, we don't think take-back programs are the long-term solution. There are a whole host of barriers to the effectiveness of take-back programs. And again, we think dealing with the problem on the front end is more likely to yield to help us bend the curve than dealing with on the back end with take-back programs. So I please don't interpret me sort of. I do think they have a role. I just don't think they're gonna be the linchpin of an effective suite of interventions.
And with that, I'm going to turn it back over to Rebecca Cunningham for final closing remarks.